All right, we're going to go ahead and get started. I'm sure some folks are going to be joining, coming from another meeting or whatnot. But thank you all for joining us for our CHS Innovation Talk this week. We're joined by Ehi. She's going to be talking about promoting equity in maternal and child health for underserved communities, specifically immigrant and refugee populations. So Ehi is one of our Presidential Postdoctoral Scholars, and she works actively with the Maternal and Child Health Translational team, one of our highest performing translational teams. So her research focuses on addressing maternal healthcare needs of underserved populations with an emphasis on refugee and immigrant communities. Her work focuses on maternal child health, health literacy, health disparities, healthcare utilization, health policy, health services, and global health. Before Ehi starts, I'll just mention one of the focal areas of our college is precision health. And in precision health, we're not just thinking about precision at the individual level, but also at the community level. And I think what Ehi's going to talk about really fits there nicely is what do we need to improve maternal and child health outcomes within certain communities. It's not a one-size-fits-all answer, and I think Ehi's going to speak a lot to that. So with that, I'll turn it over to Ehi and take it away. Thanks for joining us today. Oh, you're still on mute, Ehi.
Thank you, Dr. I apologize for that. Thank you, Dr. Bowman. I'm very happy to be here to give this presentation and to share my research and what I've been doing with the Maternal and Child Health Translational Research Team. As Dr. Bowman said, my name is Ehiremen Azugbene. Everybody calls me Ehi. I'll just jump in to the next PowerPoint slide. So, like he said, I'm a Presidential Postdoctoral Research Scholar with the Maternal and Child Translational Research Team here in the College of Health Solutions in Arizona State University. I'll just jump in now to the introduction of what I'm going to be talking on based on the theme and the topic of my presentation, which is focused on improving maternal and child health for underserved communities with a focus on immigrant and refugee populations. I'll start by addressing the introduction under these 4 sections. I'll talk about maternal health. I'll talk about maternal health equity. I'll touch a bit on immigrant and refugee populations, and then address some success stories in the sphere of promoting health for maternal and child health for the underserved communities with a focus on immigrant and refugee populations. Okay, so to start off, when we talk about maternal health, it's basically we're referring to a fundamental aspect of well-being, looking at the health of a mother before childbirth, during pregnancy, and after pregnancy. And it's very essential that every member of all our diverse communities have equal access to quality healthcare. Why is this important? Well, quality healthcare is a big determinant of the kind of optimal health that a woman will have during her maternal or perinatal period. We see that right now. In the United States, maternal death rates are very high, the inequities are very high, and they are constantly on the rise. This is a present issue that needs a present solution to this issue. Okay, so I jump into the concept of maternal health equity. Basically, like I said, to reiterate, ensuring that all individuals, it doesn't matter what their background is, that they have equal opportunities, equal avenues for optimal maternal health outcomes. This is important because we know, just like I've said, that access to quality healthcare is a basic human right. Just like healthcare should be a basic human right, access to healthcare when we're trying to bring life into the world should be a basic human right. And we see that when we begin to address healthcare, even from the onset of the start of life, it affects your health across the lifespan. And so improved maternal health does contribute to healthier families and healthier communities. So the integral role that the health of a mother plays in interacting with the health of the child and the health of the family and of the community. And then basically addressing inequities in maternal health is crucial to reduce health disparities. I like to think of health equity in this way, giving everybody what they need when they need it. So basically, we can say, oh, let's everybody have equal care. Equality is important. But it's also very important to understand that we don't all start from the same places in life. We don't all start from the same avenues. And when I begin to discuss more about immigrant and refugee populations, you see that some people are dealing with forced migration, dealing with different things. So it's important that we address the concept of equity, not just equality, when we want to improve maternal health disparities. And then I'll talk about the fact that, just like I said, that is a present issue about the disparities in maternal health care and the poor health outcomes that Black, Indigenous, and people of color, who we refer to as BIPOC populations, and this includes newly arrived migrant communities, they do show a disproportionate excess maternal morbidity and mortality burden in the United States. This burden is exceeding what we're seeing in most developed nations, even like our neighbor here, Canada. So we do need to do a lot of work to improve health outcomes for everyone. We're seeing that just if you look at Black maternal health, which is a sphere I've also worked in extensively, you're seeing that Black women are 3 times more likely to die from a pregnancy-related cause than white women. And this is not just something that's linked to just existential factors. We're seeing other factors that are contributing that are increasing this disparity, such as variations in quality of healthcare, underlying chronic conditions, structural racism, and implicit bias. I would say when you look at the variations in healthcare, the underlying chronic conditions, sometimes we're not seeing a lot of tailored care for populations like Black women. I think there was a story recently, I was looking at somebody who was as important or as popular as Serena Williams, talking about her birthing story and how people didn't know that she was dealing with blood clot and was being like dismissed. And we see a lot of people talking about dismissive behaviors from providers because sometimes they're just generalizing their care. They're not putting equity at the center. They're doing things in a way where they may not be as knowledgeable. So we need to begin to have those very tailored care where people begin to understand the issues that certain populations face and then begin to tailor care to them to be able to improve their health outcomes. Okay, so I'll jump right in now to immigrant and refugee populations, which is very dear to my heart because I'm an immigrant. I'm not a refugee, but I've worked this population for a long time. And we see that diverse groups, just like we said again, are facing unique challenges in accessing healthcare services. Migration is an important social determinant of health that can really affect health outcomes. This is because even before people migrate, they're already experiencing certain conditions that could exacerbate or put them at risk for poor health outcomes. And then you see that maternal health challenges, they are frequently encountered by women who are migrating or moving from low-income countries to high-income countries, such as the United States. They're experiencing forced migration. They're experiencing a lot of, problems even before they come that need to be addressed, even on a mental level, on a physical level. And then we begin to see what happens when they begin to interact. So it's a myriad of factors because we begin to see some kind of intersectionality of what's going on by being members of BIPOC populations and also being immigrants. So they're encountering obstacles that include economic, social, linguistic, cultural adjustments when they're seeking access to suitable health services. We in public health like to address what we call the social determinants of health, because we know that one of the major determinants of a person's health is the access to resources, is the access to wealth. And we see that because when they come in, most of the time, they tend to qualify or be categorized under a socioeconomic status that is not really high, maybe low. We begin to see that many people from racial and ethnic minority groups are prevented by the socioeconomic of health, where they stand from having fair opportunities for economic, physical, and emotional health. And this in turn also affects maternal health. So I'll talk about a few success stories because it's not all gloom and doom. It's good that we talk about some of the things that have been done in this fair to address these problems and continue to go in that direction. To advance maternal health equity, I'd say like a resounding gong that to do this for immigrants and refugee populations, it is a shared responsibility, something that requires collaboration, it requires cultural sensitivity, and it requires innovative solutions. And one of the innovative solutions that I have seen in my collaboration with the Valley-Wise Health Refugee Women's Health Clinic, this is a pioneer refugee women's health clinic that was founded by one of my mentors, Dr. Krista Johnson-Agbaku, who used to be at ASU, but has moved on now to UMass. And also founded by members of the refugee community who I'm also collaborating with, Ms. John Ehiremen. And they've done a little work there where they're trying to see how they can tailor care to improve the health outcomes of particularly immigrant women, but also refugee women, to see how they can tailor care to them with the use of collaboration, cultural sensitivity, and these innovative solutions. And so we're also seeing it's important to form partnerships with community-based organizations, local healthcare providers, and government agencies. You can't do this alone. African proverb says, if you're going to go, very far, you want to go with people, you don't want to go alone. So one of the work I have done, I'm a big proponent of community-based participatory research and community-engaged research, even in my background research, because I believe that it's very important to involve communities, especially communities that are unique or that have different cultural sensitivities than is the norm, to make sure that whenever we're proposing solutions to their problems or interventions, we include them from the ground up to ensure that it is successful when we get to the end of that rolling out that intervention. And then collaborative initiatives can also amplify the impact of maternal health equity programs, such as what I'm involved in with the MCHTRT. What we do there is that we're bringing together community-based organizations, healthcare providers, we're bringing together researchers like myself to think of how to work together to advance maternal equity. We have a conference that's coming up pretty soon. And so these kinds of success stories are important in moving the research forward, but more still needs to be done. Okay, so I'll talk now basically about my research. I'm going to split it into two. I'll be talking about my background research based on the maternal health experiences and healthcare utilization of African immigrant women. And then I'll talk about my current research projects based on an MCHTRT mini grant that I got last year to work on the impact of the healthcare system on the maternal health seeking behaviors and health experiences of refugee women who live in Phoenix, Arizona. So in talking about my background research, I'll address the purpose of that study, the research questions, the Anderson healthcare utilization model that guided the study, the settings and participants, themes of the interview, which are the results of the study, and what the major contributions to science were. It has been published. If you want to look at, I'll address some of the publications, but one of them is written here based on a review that I did. And as I discuss the results, I'll also talk about, there's a QR code there for the second publication, which was done open access. Okay, so my background study looked at the factors that facilitated or hindered the use of health services for African immigrant women in Clarkston, Georgia. At the time, I was doing my doctoral program in Clarkston, Georgia, and also I'm working on research there. Why am I looking at healthcare services? Like I just said, how they're interacting with the healthcare system is very integral in how their healthcare outcomes totally pan out, whether it's positive or negative. My study research questions looked at the contextual and individual factors that facilitated or hindered maternal health utilization. I also looked at how do the maternal experiences of African immigrant women influence the use of healthcare services. For my research study, I did, the research design was a concurrent nested mixed method design. I am a mixed methods researcher with a focus mainly on qualitative research. And so the rationale for doing this was complementarity. And then, like I said before, the Underserved categorization models guided my study. I administered semi-structured interviews. Qualitatively, it was a huge chunk of the study. And then I also administered health literacy survey, which is a very big part of my research interest and inquiry, because I believe that improving health literacy is integral to also affecting the maternal health outcomes of populations like the ones I'm working with. And then I also administered a demographic survey. So the Underserved categorization model, I'll touch very briefly on this. It's extensive to go into all of it, but it looks at contextual factors, which are community factors, and individual factors, which are personal factors on a predisposing, enabling, and needs level that would actually affect maternal healthcare practices and ultimately the use of healthcare services. I will refer everyone to the paper to look at it extensively. I won't go into this in this talk to discuss the model. So let me talk a bit about the settings and participants for my background study. I invited a convenient sample of African immigrant women in Clarkston, Georgia, to take part in the study. Why did I do this? This community is a resettlement area for several recent immigrants, especially people from Africa. Why was I choosing to work with African immigrants? Well, my positionality as an African immigrant was brought to bear in this respect. And then also the fact that there were lots of them who were living there, and they were showing that they needed research in this sphere to bring their research to the forefront. So my inclusion criteria to take part in this study was you had to be an immigrant woman from Africa between the ages of 18 to 45. I have come to the United States in the past 6 years to give you some time to actually remember your experiences, and I've given birth in the US to at least one child. So this is the organization that I worked with. It's called Women Watch Africa. They're very entrenched and based in the Clarkston, Georgia area, working on with African immigrant women. But they work with a myriad or several other migrant populations, but they focus on African immigrant women. What I did then was to volunteer with them for about a year, and got very familiar with them. By the time I started developing my research questions, they were part of it. And by the time I started collecting data, I had very rich data because they saw me as part of them. So I think it was very important that I was very embedded within the community as I was doing this study. Okay, so let's talk now about the results, the themes from my interviews. We didn't see themes or results on every single constructs of the Anderson healthcareization model, but under the contextual characteristics, which are community factors, on the predisposing, we saw that there were themes such as community social structure, where we see that on a positive level, living in a community where there were a large number of immigrants and also services geared to that respect was predisposed them to positively interact with the healthcare system, community health beliefs. There were some that were negative, that were not in congruence with conventional medicine. For some of them, their religious beliefs were not in congruence with conventional medicine. And so sometimes it didn't predispose them to start using prenatal care early, or use healthcare services early, or interact with the healthcare system on a positive level. And then their overall maternal experiences were negatively impacted. For something on the community level like WIC, health organization like WIC, they thought that was a very awesome program, and they were very grateful for it. In terms of individual characteristics, we were saying this is factors on a personal level that were predisposing them to use healthcare services. Social support was very important to them because most people from these communities actually have a very communal sense of living. So for the ones who had it, it was a plus. For the ones who did not, it was a negative. And then there were some of them who complained of limited English proficiency in interacting or using the healthcare system, and needing interpreters to be able to improve their experiences in using healthcare services. And then perception of care. There were some of them who talked about dismissive attitudes from healthcare providers when they talked about maybe some healthcare concerns that were unique to their particular population or the way that they were experiencing chronic conditions or things like that, and they weren't getting the kind of resource that they needed from their healthcare services provider. Looking at also personal and endemic characteristics like healthcare financing. For those who had it, it was a plus, it was positive. For those who did not, even at my level, I think there's some aspects of health insurance that I don't even fully understand. You know, so sometimes when they're coming in, some of them are coming in with different levels of literacy. So being able to understand the way the healthcare system is working, things like financing, is something that's for some that didn't understand it was a negative. And then the long wait times and the lack of transportation was something that they also complained about. Some of them coming into the United States, trying to figure out how the bus system works. And when they're coming in, they don't have vehicles yet and things like that. And when thinking way back when as a student, when I was trying to understand the transportation system, I would always present late for the bus and be left behind. So I think being able to have that acculturation assimilation factor into the United States was very central in how they were also going to interact with the healthcare system. And then for need factors, there was fear of medication for most of them. Most of them didn't want to have the epidurals. They'll say, oh, I saw a woman who said she took it and she had got paralyzed or had a bad experience. There was fear of obstetrical interventions, which is also linked to the next need factor, the impact of female genital mutilation. Most of them from these countries have experienced female genital cutting or female genital mutilation prior to coming to the United States. And sometimes the doctors, depending on the severity of what has happened to them, may not know how to tailor care to these women and tend to just refer obstetrical interventions. And so most of them will be afraid they're going to cut you up once you get to the hospital. So they're thinking of other avenues and ways to circumvent the system or, you know, figure out how to interact with the healthcare system. So this is the to the right is the QR code for the paper that I published based on the African immigrant women's maternal health experiences in Clarkston, Georgia, as a qualitative study. So looking at the contributions to science is one of the few investigations on maternal health care utilization for African immigrant women. I think there's been one more study since then, working with women in Clarkston, Georgia. But this basically adds to the limited body of research generally on the African immigrant women and immigrant women in general in the United States. So the long-term goal is to have them presented in research to address barriers to the use of maternal health care by designing tailored interventions to address their care. Okay, so I'll move on now quickly to talk about my current projects as a postdoctoral research scholar with the Maternal and Child Health Translational Research Team, which kind of morphs from my background study on the impact of the healthcare system on the maternal health seeking behaviors and health experiences of refugee women in Phoenix, Arizona. I'm working as the lead for this project with a supporting team that you can see both from ASU and the Valley-Wise Health Refugee Women's Health Clinic. So the purpose of this project is to contribute to a broader research initiative to investigate the influence of the healthcare system on maternal health seeking behaviors and the health experiences of refugee women who live in Phoenix, Arizona. So this study will examine the maternal seeking behaviors, their experiences, their unique care needs of African refugee women. Why am I starting with them? In working with the Valley-Wise Health Refugee Women's Health Clinic, working with a lot of community-based organizations, I see that there's a large proportion of African immigrants who are they're the most refugees right now in Phoenix, Arizona, and more are set to come to be resettled here. I'm starting with them also because of my positionality as an African immigrant woman. I intend to expand to all refugees, but when you want to eat an elephant, you start with the toes and then you go to the whole elephant. So the project is in the initial phases of preparing for data collection, which will involve conducting interviews with the study participants at Valley-Wise Health Refugee Women's Health Clinic. This is going to be also a basis for a larger research that I'm trying to do for a larger grant, but just starting with this as a preliminary strategy to start working with these refugee women. Okay, for settings and participants, the inclusion criteria to take part in the study I'm going to be inviting African resettled refugee women between the ages of 18 to 50 who have come to the United States in the past 6 years. For the same reason, I want them to be able to remember their experiences. They're giving birth to at least one child in the United States, and they have received maternal health care at the Valleywise Health Refugee Women's Health Clinic in Phoenix, Arizona. We're going to be collaborating with the cultural health navigators there to invite women for the study and also help to conduct the interviews with the participants for this study. So I hope that the results of my study, excuse me. So I hope that the results of my study will position the health system to effectively advance maternal health and maternal and child equity and improve maternal health outcomes for refugee women. First, the ones who live in Phoenix, Arizona, who are resettled here, and then advance the research narrative to advance the outcomes for all refugee women who are resident in the United States by designing tailored intervention to address barriers to the use of healthcare services. So going forward, I intend to build on this current study and continue to advance maternal equity for unserved populations. I'm looking to collaborate with anybody who is interested in this fair. I've already had some students who are interested in working on this particular research with me. I'm looking forward to doing good work that would inform the development of research programs and involve community partners, involve researchers and other partners in all aspects of the research process. I will conclude by saying that, by reiterating what I said at the beginning of my presentation, that to advance maternal equity for immigrants and refugee populations, this is a shared responsibility, and it requires collaboration, it requires cultural sensitivity and innovative solutions. I'm going to thank my community partners who have been working with me, the Valleywise Health Refugee Women's Health Clinic, the Refugee Women's Community Health Advisory Coalition, International Rescue Committee, the Somali American United Council, and many others who I'm working with. And I'm going to be inviting people from the research community, the student community, to join with me to address these communities. I think it's a unique challenge that we all have to come together to do, and to result in a more equitable healthcare system when we do this. These are my references. Thank you so much for listening to my talk and my presentation. And yeah, thank you for having me.
Wonderful. Thank you, Ehi. That was a really great talk. So just a note, this is our next talk by Dr. Ehiremen. But we do have time for questions. So feel free to unmute yourself and ask a question of Ehi.
Hi, Ehi, it's Marisa. We had a chance to meet before. Great work. I enjoyed hearing about it. What are some things that you think will be obstacles to doing this work, the project at Valleywise?
Currently now, I'm not. I'm just completing my IRB now with them for this initial interviews. I have not really faced any obstacles to doing the work. I think when you're working with a healthcare system, sometimes things are really slow because they're trying to protect, there's a lot of things with HIPAA and all that stuff. They want to protect their the patients to make sure that things are done as they should be done. So things can move a little slow, but I have not faced any so far. I hope I don't face any, but I haven't faced any obstacles to working with Valleywise Health. This is basically going to be part of what I'm trying to craft for a study that I am trying to design as a K-grant. Basically, this is going to be preliminary data, which I'm going to start collecting data. I'm meeting with John, one of the co-founders of the Refugee Women's Clinic, to begin to give her the go-ahead for the CHNs to collect the data on my behalf. The good thing is that just the way I volunteered for a year for my background research, they are very conversant with the population. So when they talk with their own population, they're able to get very rich data They are part of the community. They are stakeholders. So what we do is we work with them. We pay their per diem. They're factored into the small grant that I got to get remunerated for that. And then we've been talking about this for almost a year. We're about to hit the ground running now. That things can be a little slow when you work with a hospital, but I haven't faced any obstacles. Dean Kumrod, who is the LBGYN lead, has been very supportive of my research, even gearing it towards the direction it has gone to, knowing population. I used to attend the expectant mothers class I was doing that for almost about a year when it was convenient for me. I go for most of their programs when they're doing stuff. I've presented this research at Valleywise Health to the population, to the community stakeholders there at a coalition meeting. And so far, I've not experienced any barriers. I just think that sometimes I had to be an ARA with them. So it takes a long time to get all that going, but they've been very receptive to my work. I think they want people to actually move the research forward. It's faster when you work with the CBO sometimes because they don't have all these loopholes to check and balance, but I haven't faced any obstacles so far. I hope I don't face any, going forward.
Great. I guess so let me ask a different way. You have an engaged audience here. Are there things that you're anticipating that you will need to do this work? I know you have some great postdoc mentors, but just thinking more broadly, like, I don't know, you didn't mention this specifically that I caught, but are you going to have access to Valleywise's EHR data so that you could identify, quantitatively the number of people who might meet study criteria or other descriptors, sort of outcomes that might reflect quality of care, timely access to care, things like that you can pull down some quantitative data for? Is that a possibility and something that you may need assistance with?
Yes, so currently I've been incorporated into a grant that they got to actually work on data dating back to like 15 years. It takes a while for the data to become malleable for people to use. I'm not a very deep context expert, but I'm going to be getting help in that respect to actually analyze some of these things that you're talking about. They're allowing me to lead whatever inquiry I want to from the data and supporting me with that. Interestingly, we're going to be having a meeting after this one today. We have meetings every Thursday to try to move that forward. So yes, I'm going to be having access to their data to be able to, part of the grant that they got from being funded by the Flynn project. So I'm going to be having access to that to be able to look at these kinds of variables that you're talking about, and then have that be a part of my study aims for what I'm doing for the larger research initiative, to look at that on a quantitative aspect, and then going forward, begin to think of just basically what I'm looking at a priori, what I'm thinking will be happening in the data, what I'm looking at with the interviews, what I'm looking at in the research space, in the research literature. I'm thinking about developing something that would address or improve their health literacy in terms of developing some kind of app that complements the work that the cultural navigators are doing to help them to navigate the healthcare system in a more cost-effective, in a more improved way. So yes, I would, any support I can get, the more mentors, the merrier. I'm never gonna throw away help. If somebody wanted to help me, I'll say, yes, please help me. Yes, but currently I am, they've included me, my current mentors, Krista Johnson-Agbaku, who even though has moved on, is still on that team, and Dr. Katie Burkell have included me in what they're doing and analyzing the data. I'm very happy to have more people jump in and hold my hand to get to where I want to go to. But yeah, that's what I'm doing with that. I hope to have a 3-tier aim, where what I'm doing now currently will be a first aim that is a preliminary data thing. The second one will be the quant thing you're talking about, and then the third would be the app that I'm trying to test, and see if that works, I can scale that up in the future.
Great, thank you. Best of luck. That sounds awesome.
Thank you so much, Marisa. Nice to see you again.
Yeah, you too.
While others are formulating questions they may have, I'm just curious about sort of the social connectivity amongst refugee women, particularly postpartum. What is the social environment like, both familial and then broader within the refugee community? How tight-knit is that community?
I'd say that it's a very tight-knit community. This is because even in my background, most times the African communities or the community, most of them are refugees who come from the Middle Eastern countries, or most of them come from Asian countries or come from African countries that tend to have a very communal sense of being. So it's very communal, I'll say that. So using stakeholders is very important in interacting with the community. Being embedded with them is very important, interacting with the community. So it's very communal. I remember just thinking about my background, research, and what I'm doing now. When I used to go for their programs, there would always be a meal. You know, the last time we had, I think it was a Thanksgiving thing. I took my jollof rice dish. We had it's always gonna be like you want to be in a community kind of setting, to let them relax and do and talk and do what they need to do. So there are many avenues. I've attended a lot of their refugee baby showers, things that they're doing. You know, just so that I become a familiar face with them, that they see me. And after a while, they don't see me as Dr. Ehi, they just see me as Ehi. And they feel like they can actually, when it's time to interact or do interviews or whatever programs, they feel like you're part of them. And I think that's something that one of my mentors, Krista, said to me, that after a while, she felt like, and she was born and raised there as an American, but after a while, she felt like she was very much part of them. She wore the gear, she felt, because when you embedded in them, it's very communal. So you saw in my research that the ones who had such supports, they didn't struggle too much. Like in my background, when a woman gives birth, they have something they call omugwo, where your mother-in-law comes around, your family members come around, and they support you through that. So when they come to the States and they don't have that, it's tough and difficult for them.
Yeah.
If that makes any sense. So now the community now begins to play that role for them. The community center, the religious bodies begin to play that role for them. So in anything you're going to do with them has to do something on the community level because of the way their natural sensitivities are, kind of. So yeah, it's very communal. It is.
Great, thank you.
You're welcome.
Ehi, this is Elizabeth. Sorry, I'm off camera. I'm actually driving to. I'm driving to a conference in Flagstaff right now.
I know that name. That's a name that, but my brain was freezing, kind of.
Yeah, no worries. I don't actually have a question, but I just want to say that I know you and I have worked together on a couple of refugee projects through ASU, and I had no idea that you were so deeply involved with Valley Wise's Refugee Women's Health Clinic, and I just want to shout out to you how amazing this is. And I am definitely, now that I know that you're so embedded, I'm going to be reaching out to you more because I would love to be a student that helps you along your way if you need any additional service.
I love working with you, please.
Yeah, I mean, I'm like, oh my gosh, she's speaking my language. Like I worked for the International Rescue Committee for like 6 years and volunteered for them for, a decade before that. So anyway, I'm just really excited about the work that you're doing. And I just wanted to say fantastic presentation. And I'm excited for you and I to maybe look at ways that I can help you as you move forward in this.
Thank you so much. Thank you. I appreciate it.
All right, other questions? Okay, with that, I guess we'll give everyone back another 15 minutes of their day. But Ehi, maybe just one more huge thanks to you, Ehi, for that great talk and sharing your research and your passion for working with the refugee community. It's really remarkable, the work that you're doing. So thank you so much.
Thanks,
And-
everyone. Thank you so much. I think I'm doing something with the well-being study too, but that's their thing. I was supporting them. I enjoyed what
Okay.
they were doing too, but anything that has to do with that, I'm game. I'm very open to working and moving the research forward.
All right. Well, I think we've got open invitation for collaboration, I think is what that means.
Yes, yes.
All right, wonderful. Well, thank you all for coming. We appreciate it and see you next week.